Thank you for joining us for this edition of Saving Lives, Healthy Conversations. Our topic today is public health hot topics, what a health advocate should know. We are joined today by Zev Goldberg. Zev is a rising junior studying public health, promotion, and education, and he serves as an undergraduate assistant here at the Center for Community-Based Partnerships. We are also joined by our Saving Lives Advisory Group member, Dr. Pamela Payne Foster. Dr. Foster is trained as a preventative medicine public health physician, a professor of community medicine and population health. She serves as the deputy director of the Institute for Rural Health Research, as well as a senior fellow of strategic partnerships in the Office of Academic Affairs here at the University of Alabama. She has led a team focused on developing and testing HIV anti-stigma intervention in rural African-American churches throughout Alabama, and really serves as an expert throughout the nation. And so, Dr. Foster, we're so thankful to have you on for this conversation. At this time, I'd like to turn it over to you for your presentation.
Thank you, Dr. Pruitt, for that gracious introduction. And I'll just get started. Oops, I'm not sharing my screen, am I? Sorry about that. Share my screen here. And so what I thought I'd do today, we know we're dealing with a pandemic currently, COVID-19, and we know pandemic means an outbreak that's global. So we're not just here in Alabama, but throughout the world. But in addition to that, I thought I'd also kind of talk a little bit about my research area, which is HIV/AIDS. Okay, so I wanted to just sort of give an overview of health disparities in COVID-19, and then talk a little bit about some of the work we've been doing in our unit around testing for COVID-19 in rural Alabama, and then another study I'm working on with a colleague from Brown University, where we're talking about HIV hotspots in the deep South. We're working in 3 states, Alabama, Mississippi, and Arkansas. And then we will answer questions. So I love this slide because it really depicts, what really health disparities are all about. So this quote says, when white folks catch a cold, Black folks get pneumonia, which really says it all. So we know, and you probably heard, that COVID-19 is disproportionately affecting Black, Indigenous, Latinx, and other people of color the most. And I'm going to show you a little data from the Racial Data Tracker. It's a collaboration between the COVID Tracking Project and Boston University Center for Anti-Racist Research. We know in Alabama, our population is about 27% African American, but, and let me just say before I get into these cases, some of the difficulty is really getting the data and making the data transparent so that we really know what's going on. So we do know that early in the epidemic, some states weren't really splitting out the demographics by race. So that's really important so that we can really kind of pinpoint and understand the disease and really attack it where we need to. But Alabama started collecting, I think around April, race data in COVID, and you see disproportionately African Americans, around 43% cases of COVID and 43% deaths. And this does fluctuate with time, so it's gone in between 40 to 50%, definitely disparate. This shows a slide, and most of the advocates will know about the Alabama Black Belt. Because I work in the Institute for Rural Health Research, our focus is rural Alabama. And our medical school where I work, College of Community Health Sciences, is actually a branch campus of UAB School of Medicine. So our emphasis is on rural areas. And I particularly have worked and concentrated on working in the Black Belt area. And you see, so it fluctuates between 12, 19 counties, and you see in yellow here where the traditional Black Belt counties are. Early on, we received a call in really March when the epidemic hit from a mayor in Livingston, Alabama, which is in Sumter County, really wanting us to come out and doing testing, to do some COVID testing. As you know, testing has not been really readily available in throughout the U.S. Not easy, not accessible. Sometimes it cost. We were able to get with the mayor of Livingston a Alabama Power Foundation grant, which really paid for anyone who was not insured to get the test. And we've had 16 testing events in 5 counties. You see the counties here: Pickens, Greene, Choctaw, Perry, and most of the work was done in Sumter, though. We were there for about a month and a half. We started April, going really up to July, testing weekly, actually 2 times a week initially, and then going weekly. So we've seen 637 persons who were screened for testing. 410 of them were tested, and 48 were positive. So the positivity rate is somewhat higher than the state and national rate at around 15%. The other news is that, of course, when the epidemic first hit, the epicenter was Birmingham, some of the larger cities, but you cannot rule out the rural counties. And if you see here, Lowndes County, which is a really small county, 9,000 people, is listed now in the country in the top 20 with COVID death rates. It's a county, it's actually listed as number 11. So it has a death rate of 254 per 100,000 persons. And it is, as you know, mainly African-American, 74% African-American. So the question is why? Why are we seeing disproportionate rates in African-Americans throughout the country, and particularly in Alabama? So I can tell you, when I did the testing, the majority of the persons that came out to get the screening were what we call essential workers. So they definitely worked in healthcare facilities, they worked in nursing homes, they worked in factories, they worked for waste management, they worked for city government. So that's essentially what we saw. They also tended to be in, and so with that, with the essential workforce, that they tend to be in lower paying, less stable jobs where they really don't have the flexibility to work at home. That's why essential workers. We also know that there is discrimination in healthcare in all systems, as we're going through this with the criminal justice system with the recent George Floyd murder. But it's not just the criminal justice system, it's not just education. Healthcare for a long time has talked about these health inequalities. And we know that there are disproportionate rates of diabetes, high blood pressure, asthma, which really puts persons at risk for more severe COVID-19. I can't tell you, almost every other car, people had either diabetes, high blood pressure, or both. In addition, other diseases like sarcoidosis, other lung diseases, lupus as well, which put them at risk. So definitely disproportionate in our communities. And some would say because of some underlying racism within systems, even provider bias, that has contributed to some of these inequities in healthcare. Housing, of course, is an issue. Many of the cars that would come and get the testing had 4+ persons in the car. So generational, intergenerational persons living in a house, more crowded, those issues. And let me just say also with healthcare, we know that transportation is a major, and that really goes to the last point, healthcare access and utilization. Besides more Black and brown people being uninsured, there's definitely transportation issues, and particularly in these rural areas where we know in Alabama, we don't have good mass transportation at all. Childcare issues, the ability to take off work. We didn't see a lot of Latino persons to come get screened, just a few, but we know that's a growing population in Alabama and even in rural Alabama. But the major issue that people talk about is really this distrust of healthcare systems by communities of color. And of course, we can't forget the Tuskegee syphilis experiment. We like to call it the U.S. Public Health Service syphilis experiment because the U.S. Public Health Service was responsible. Although Tuskegee University played a role, it was really the federal government that perpetrated this experiment. And as you know, most people know it's the longest non-therapeutic clinical trial in U.S. history. It was conducted from 1932 to 1972, so 40 years, where the men did not receive any medical care for their syphilis. In 1932, there was not a treatment for syphilis, but around the 50s, late 40s, 50s, penicillin was founded and there was a cure, and these men did not receive that treatment. So it really is sort of a signal of the misuse of science and the abuse of science by scientists. So that still resonates with many, particularly in Alabama, where some of the descendants, we know Macon County is in the Black Belt, and some of the descendants of the study still are alive. So that definitely plays a role. And if we look at really talking about a vaccine, this study talks about 1,400 people being surveyed about what they thought about a COVID vaccine. The question was, if a vaccine for COVID-19 became available, would you be willing to take it? Nearly 2/3 agreed that they would, but race and ethnicity mattered. While 70% of the white people agreed, just 62% of Latinos, and look at this, 44% of Black people said they would. So great distrust, lots of reasons, and we can kind of talk about that as well, but we can't forget the syphilis study. So I'm going to shift to HIV. A lot of parallels between COVID-19. Both are infectious diseases. Both you get from a virus, the HIV virus in this case. And so this just shows a map now, and I think this is current. I can't remember exactly which year, but this is 2018, it says on the slide. The darker the coloring is, the more people are affected by HIV, so the rates are higher in those areas. It used to be, of course, in the 1980s when HIV first was found to cause AIDS. Large metropolitan cities were affected, mainly in California, San Francisco, New York on the East Coast. But if you look now, it's kind of moved down to the South. And not only is it in large metropolitan cities, but in small rural areas where I study. And that really got me interested in looking at HIV in the Deep South, because the Deep South now is the epicenter, looking at why the rates are increasing. And one of the theories is that there's more stigma in the Deep South around HIV. When I moved to Alabama from New York City, the New York City area, the first thing I noticed was that nobody was talking about HIV, although the rates were increasing. And in a study I did with a colleague in the School of Nursing, we asked people living with HIV in Alabama, rural Alabama, where did they feel most stigmatized around HIV? And their answer was the church. So that's really what got me into looking at stigma in church and faith-based settings. And although that's, my answer, my thought when I got that statistic and got that theme from our research, what a shame. And maybe we should be, working with faith leaders to really change that, turn that around, and really look to faith leaders to help us with HIV prevention. And I've been successful in doing that. But this study actually takes it a step further. A lot of the work I've done has looked at, trying to get pastors to really talk about HIV prevention. Tough topic for church leaders, because you really have to kind of delve into sexuality, which is a tough topic for most pastors, and other things like drug use. But we've been successful in doing that. But we also want pastors to be updated. And so now in this study I'm doing with Dr. Amy Nunn, we're looking, of course, where the epidemic is in the Deep South. We've had virtual focus groups with pastors in Alabama, Mississippi, and Arkansas, And so far, we've talked to 70 of them. And we really wanted to ask them questions about their current knowledge of HIV, and really to see if they're really understanding what's going on around HIV treatment. So these are the 3 questions we asked. Have you heard of the Ending the HIV Epidemic National Plan? Do you know what U equals U means? And do you know what PrEP stands for and what it does? And just preliminarily, I can tell you most of the pastors could not answer any of these 3 questions. So what I thought I'd do is just answer these questions for you. So the whole idea around these questions has to do with, I think in 2010, the first International AIDS Conference was held here in the US, in Washington, DC, and I happened to go to that meeting. The reason it was the first time in the US was there was a law in the books that said that people with AIDS could not come in from other countries, couldn't come into the United States. So the International AIDS Conference never was held here. And of course, Obama reversed that decision, and it was held in DC for the first time. During that conference, the whole conference was about treatment as prevention. So really looking at this area, treatment as prevention, he came up during his administration with a national strategy to really end HIV/AIDS. And during Trump's administration, he's recently come up with this EHE, Ending the HIV Epidemic. And these are the 4 strategies. Let me go back for a minute. This treatment as prevention, and I think I have it in the next slide, is really the whole idea of if we can get people tested, because many with HIV don't know they have HIV. And that's pretty interesting that there's a little parallel to COVID-19. There are some people who are asymptomatic and don't have any symptoms. So really the need to test widely is important, and the same thing for HIV. And the other thing we learned was that if we could get people tested, that they knew their status, that they got into treatment to get antiretroviral drugs, if they stayed on that treatment, and if they brought their viral load down, they would be undetectable. And if they're undetectable, then they would be, they could not transmit it to other people. So essentially, you could really end the epidemic that way. So if you see in this slide, the top part, getting people tested, and those people taking their medication daily, then they would get an undetectable viral load, and then they would not be able to transmit it to others, to their HIV negative counterparts or partners or friends or sexual partners or etc. So this is essentially what treatment as prevention is. So these are the strategies with the ending the HIV epidemic. Make sure you get people tested and diagnosis so they know their HIV status. So that's the first one, diagnosis. Then get them linked to HIV care, and not only linked, but keep them in care so that their viral load comes down. And then we have prevent here, which is PrEP, and I'll talk about PrEP in a minute, which stands for pre-prophylaxis prevention. And then respond is to respond to any epidemics or any outbreaks that you might have around HIV. Okay. So let me see if I can do this YouTube video about PrEP.
Preventing HIV and having safe and healthy relationships are an important part of sexual health. We'll take you through an overview of PrEP with PrEP 101, show you how to access PrEP, and let you find out if PrEP is right for you. PrEP is an HIV prevention option that works by taking one pill every day. PrEP stands for pre-exposure prophylaxis. When taken every day, PrEP can provide a high level of protection against HIV and is even more effective when it is combined with condoms and other prevention tools. People who use PrEP should take the medicine every day and return to their healthcare provider every 3 months for follow-up and prescription refills. Now, let's take a look at the numbers. In several studies of PrEP, the risk of getting HIV infection was up to 92% lower for those who took the medicines consistently than for those who didn't take the pill. Some people in clinical studies of PrEP had early side effects such as upset stomach, loss of appetite, or mild headache, but these were all mild and usually went away in the first month. How do you start PrEP? Talk with your doctor or healthcare provider. If you and your provider agree that PrEP might help, get tested for HIV and other sexually transmitted diseases, and to see if your kidneys are working well. If PrEP is a good option for you, your provider will give you a prescription. PrEP is covered by most insurance programs. If you don't have insurance, your healthcare provider can direct you to medication assistance programs that may help pay for PrEP. You can also contact your local health department and HIV and AIDS service organizations for more information. Thinking about PrEP to prevent HIV? Here's what to do next. Make a list of why you think PrEP would be right for you, and do your research and seek out information to help you decide. Also, think about your routine and what might make it easy or hard to take a daily pill. And always know you can call your healthcare provider if you have more questions. But what are the best questions to ask? Would PrEP be a good option for me? How much would PrEP lower my risk of HIV infection? What else can I do to lower my risk of HIV infection? Can I get help paying for PrEP? Are there any side effects to PrEP? How often will I be tested for HIV and other STDs? Will you prescribe and manage PrEP for me? If you decide PrEP is right for you, definitely take your pill every day. Follow your healthcare provider's advice about how to take your pill. This will give it the best chance to prevent HIV infection. Tell your healthcare provider if you have trouble remembering to take your pill or want to stop PrEP. Remember, you are in control. Get informed. Make the right choice for you. Check out the Start Talking, Stop HIV website for resources.
Okay, just to wrap up, that was another video, but a little bit more information. U equals U is undetectable equals untransmittable. And PrEP, of course.
I found out I was HIV positive.
Let me stop this video, I'm sorry.
May 20th, 2000. I was the 20th
I thought I stopped the share.
On the 20th of May, and I was 20 years old. So I swore I was a lucky person at that point. I received a call from partner notifications from partner notifications.
Okay. This stuff is tricky, right? U equals U, undetectable equals, undetectable equals untransmittable, and PrEP, pre-exposure prophylaxis. So those are real tricky sort of terms. And one of the things we did with the focus group was to have the pastors really tell us if that works for them, or if they had some better ideas about how we could kind of market this information to get it out to the community in a better way. So we really see the pastors as partners with us in really conveying this sort of complicated health information and get it out to the community. And they're willing to do that, and we're appreciative of that. So with that, I will end, and Zev, let's take it away with the questions.
Awesome. Thank you so much for joining us, Dr. Foster. That was a really interesting presentation. How did you first become interested in the role of churches in promoting health, and specifically in their role in eradicating HIV?
So I think I told you, talked a little bit about it, but I moved to Alabama about 15 years ago from the New York City area, and most of my life I've lived in big cities. So this is the first time really coming to a rural area. Before UA, I was working at Tuskegee University in Macon County. And so I had always been involved with HIV activism, advocacy. And so I noticed right away when I moved to Alabama that nobody was talking about HIV. Even on some of the advocacy days like World AIDS Day, everybody knows all over the world is December 1st, December 1. In big cities, there's a lot of advertisement and a lot of talk about HIV. Here it was pretty quiet. Not campaigns on the radio, some of the AIDS service organizations, although I think they do a fantastic job, but it's just a different kind of advocacy. So I noticed the advocacy was lower. And that's what sort of got me asking the question, why? I know that the church, this is what we call the Bible Belt. And most people really look at church as a pivotal part of their lives, very important to them. Most people here, it's been shown that the South is a little bit more religious. People are a little bit more religious in other parts of the country. So I said, maybe it's that, and then started kind of doing some research and putting two and two together. There, a few other researchers were talking about those issues, but not in the Deep South. most of the research had been done in big, larger cities. So that got me interested, and really, it's just been a great partnership, I think, to talk about. On the one hand, the stigma that's inflicted on people living with HIV by the church is sad. But at the same time, I saw it as a missed opportunity to really kind of try to bring the two groups together. And that's some of the work I also do, not just sort of revealing what the statistics are, not just decreasing the stigma in congregations, but I really want to try to bring HIV persons into the religious fold as well. And so kind of bridging the gap between the two. That's another goal of mine.
That makes sense. Yeah. I mean, I think it's really important to like meet people where they live, specifically with health issues.
Right.
And church is so important to people. So
It is. Particularly, let me just say the Black church in particular, it's not a monolithic church, but we know the role of the Black church, the sort of Black denominations, Black congregations in the civil rights movement in the 50s and 60s. And so that sort of model of churches being more than just spiritual, they're also, they're economic centers, they're political centers. It's interesting, I had this argument with, I belong to a multiracial church in Washington, D.C. And so when candidates come and campaign, that's not unusual in Black congregations. And he was really irritated by it. This is white, gay male friend of mine. I said, but that's what we do historically. So historically, we have to really understand how important it is for the Black community. I have a friend who's a researcher at UA. She doesn't understand why I do this research, right? She says it's not low-hanging fruit in HIV prevention. But she's also not from America, and I'm not sure she really understands the historical importance of the church to the African American community. And I think I do. I understand it wholeheartedly. And that's why programs like Saving Lives are so important, because churches can play a key role in really addressing health issues. Not just, well, I have found that churches are much more, they're much more attracted to dealing with diabetes and high blood pressure, because those are chronic diseases that they see a lot. There was a time when there was resistance for churches to talk about HIV, because of course it's attached to sexuality and drug use, some other risk factors for it. But more and more, I'm seeing more and more pastors and leadership really addressing, because it's an issue that's affecting not only their church congregation, but the community as well. And it's so disproportionate.
that makes sense. Yeah. You talked a lot about the distrust that the African American community has for the medical establishment, just because of the really dark history in this country. How important do you think it is for medical advocates, doctors, to be creating these ties with these Black churches?
They're very important. And the other thing I always say is it can't be ignored. So I'll give you an example. I was doing an HIV presentation to an all Latino group one day. And I was telling them although the Latino numbers are not as high as African American, they're rising. And so they're a group that we're really looking at, paying attention to. So I said to them, get your HIV test. And they said, well, what about Tuskegee? And I said, what about Tuskegee? What do you know about Tuskegee? So, I mean, again, people all over the world use the syphilis experiment as an example, right? And some people are afraid to get the HIV test, because they think that, the government might be using it for genocide,
right,
for example, or, that the distrust is that thick. Same thing, I showed you the data about the COVID vaccine.
Yeah.
So the first thing I would say is you don't ignore the history. So I said to them, let's talk about it. Let's talk about the Tuskegee syphilis experiment. In fact, I agree with you. It happened. There are other events in history where we have had medical experimentation against Blacks. Latinos, other groups. Let's talk about it. I always tell my students if you're African American in the U.S., you should have a little healthy dose of paranoia, right? But at the same time, I also want to give them the facts that this is a disease that is ravaging our community. And one of the ways that we have to prevent it is to get your test, know your status, and if you're HIV positive, take your medication. So that's on the other flip side that I always have to talk about. But I also am clear that I don't ignore the history as well, because it's important to keep it in context.
That makes sense, yeah. One thing I've thought a little bit about is with the most marginalized communities having such a disproportionate share of COVID cases, and we're learning, there's long-term ramifications to this disease. How can doctors and health agencies support people who are going to be dealing with long-term COVID ramifications, specifically people who are uninsured or in communities that don't have a lot of doctors?
So it's a great question. I think Dr. Fauci said it best, that this disease is sort of uncovered what's wrong with our healthcare system. I mean, if we don't have a system that really values wellness, then we've got a sick system, and that's sort of what we have. So I've heard that people who, for example, might have diabetes, might be having some problems with their diabetes, were afraid to go to emergency rooms because of COVID. And that puts their diabetes at risk for, to have some kind of event that makes their disease worse. So these are things we have to continue to educate, continue to build the trust with communities that we work with. It would help that if we had a better healthcare system in general. So as a physician, I advocate for Medicaid expansion because that would help. If more people were insured, then they wouldn't worry about going to the doctor or going to the emergency room or having a doctor. Some people don't have a doctor because they don't have insurance. So those big things we have to kind of think about, as well as the individual cases. But I mean, even with COVID, it's such a new disease. It's a novel disease. We still don't know everything about it. Still learning. So the idea when it first came out that it only affects elderly, or people with underlying health conditions, that probably puts people more at risk. But we're finding out that young people are at risk, and they could have some of those long-term manifestations like cardiac or neurological. And I've heard some cases of that even in very strong young college students. I've heard of a couple of college athletes. So that we don't know enough to know if there's going to be some long-term manifestations. So the take-home lesson is that we probably need to make it so that nobody gets infected and flatten the curve, do the best we can to flatten the curve. We haven't done a good job with that as a country. Of course, we're all waiting for a vaccine, but it's going to take years for us to get to herd immunity. Even if we had a vaccine today, it would take a little time for us to get enough in the people that have the vaccine. You need 60-70% of the population to even get to that immunity. And you saw the statistics I showed you about who would even take the vaccine.
Right.
So it's complicated, isn't it?
Yeah.
It would be good if it was just based on the science, but we've got to add in their politics. We've got to add in their social, cultural sort of issues, our historical context. So all of those make it complicated.
Absolutely, yeah. Thank you. I thought that was a really thoughtful answer. I'm told we have time for one last question.
Sure.
My last question would be, so you have this amazing background because you are a medical doctor and you have like an MPH.
Yes.
What do you wish that you could tell people with just an MD and no experience in population health about health disparities, and basically what do you wish you could tell them?
So I am grateful. I love public health. I am grateful that I'm a physician because my specialty, we combine our clinical knowledge with population health, which you mentioned. Population health is epidemiology, the study of epidemics, And biostatistics, we have to know a little bit about biostatistics. We have to know a little bit about epidemiology. We have to look at data. So I would tell my colleagues who are clinicians, don't be afraid of data. Look at the data.
Yeah.
Really understand the data. It was interesting in a talk given several years ago. A speaker came and told us that in, I think, a European country, it might be Sweden, one of the European countries, all their medical students have to get an MPH. So this whole idea of expanding your knowledge base, not just clinically, but also to really respect the data and understand the data would probably be helpful with dealing with crises, public health crises. I'll give you a prime example. The physician in Flint, Michigan was a pediatrician, but she also had an MPH. So in addition to her seeing clinically what was happening in her practice, she also began to look at the numbers and see that the kids in Flint had high lead levels. So she was able to sort of combine the knowledge of both to really tackle that public health crisis.
Absolutely.
So I would say, don't be afraid. My clinician friends, don't be afraid of the data and really use the data to really look at the whole population.
Yeah, I think that's a great answer. And I just want to say thank you so much for coming. Sure. This was really interesting and engaging.
Thank you.
Absolutely.
Thank you.